Welcome back to Mastering Medical, Part 5 of our Renal Rapid Review. Acid-based questions are not hard, they are just badly approached. Students try to interpret every value at once. The fix is a fixed order. Find the primary abnormality first, then check whether compensation is appropriate, then calculate the gap. In this video, we do potassium on the monitor, then build that acid-base sequence. Then finish with the renal tubular acidosis. Let's start with the ECG, because that is the one that can kill the patient in front of you. A dialysis patient has tall peak T waves, disappearing P waves, and a widening QRS. Potassium changes the cardiac membrane potential, and the monitor shows it before the lab does. High potassium and low potassium produce opposite pictures. Peak T waves or flattened T waves with U waves. Hyperkalemia progresses in a predictable sequence, and the sequence is the answer to most questions. First, the T waves become tall and peaked, then the PR interval prolongs, and the P waves flatten and eventually disappear. Then the QRS widens, and if it keeps going, the QRS merges with the T wave into a sine wave pattern, which precedes ventricular arrhythmia and arrest. Causes are kidney failure, potassium-sparing drugs, AC inhibitors, acidosis, and tissue breakdown like rhabdomyolysis or tumor lysis. Treatment order matters. Calcium gluconate first to stabilize the membrane, which does not lower potassium at all. Then insulin with glucose and beta agonists to shift potassium into cells. Then something that actually removes it, like a binder or dialysis. Hypokalemia is the mirror. Repolarization is delayed, so T waves flatten, ST segments depress, and U waves become prominent, which makes the QT look long when you're really seeing a QU interval. Causes are loop and thiazide diuretics, vomiting, diarrhea, and alkalosis. One clinical pearl: if potassium will not correct, check magnesium, because low magnesium causes refractory hypokalemia. So scan in order: T wave height, P wave visibility, QRS width, then U waves. Now, metabolic acidosis. A patient has a low pH and a low bicarbonate after severe diarrhea, and the anion gap is normal. The anion gap answers one question, and it is a mechanical one. Was acid added to the blood, or was bicarbonate lost from it? The anion gap is sodium minus chloride plus bicarbonate, normally around 8 to 12. When an acid is added to the blood, the hydrogen ion consumes bicarbonate and leaves its own anion behind, and that anion is unmeasured, so the gap opens. Think lactate in lactic acidosis, keto acids in diabetic or alcoholic ketoacidosis, retained acids in kidney failure, and the toxic ingestions: methanol, ethylene glycol, and salicylates. When bicarbonate is lost instead, the kidney holds on to chloride to preserve electroneutrality. So chloride rises exactly as bicarbonate falls, and the gap does not change. That is why normal gap acidosis is also called hyperchloremic acidosis. The big causes are diarrhea, which is the most common one worldwide, renal tubular acidosis, urethral diversion, and acetazolamide. Always correct the gap for albumin. For every 1 gram per deciliter that albumin falls below 4, add about 2.5 to the measured gap, because low albumin can hide a real gap acidosis in a sick patient. Now the step that has to come before the gap. A patient with a COPD exacerbation is acidemic with a high carbon dioxide and a high bicarbonate. Both values are abnormal, so which one is the disease and which one is the response? The pH is low. Which value moved first? Both disorders can show a high bicarbonate and a high carbon dioxide, which is exactly why students get lost. The way out is to identify the primary abnormality, and the primary value is the one that explains the direction of the pH. In respiratory acidosis, the primary problem is a carbon dioxide above 45 from hypoventilation. Causes are central nervous system depression from opioids or sedatives, neuromuscular disease like myasthenia or Guillain-Barré, chest wall problems like kyphoscoliosis and obesity hypoventilation, and severe lung disease. The kidney compensates by retaining bicarbonate, and the amount tells you the timeline. Acutely bicarbonate rises about 1 for every 10 that carbon dioxide rises, but in chronic retention it rises 3 to 4 because the kidney has had days to adapt. In metabolic acidosis, The primary problem is a bicarbonate below 22, and the lung compensates by blowing off carbon dioxide. Use the winter formula to check it. Expected carbon dioxide equals 1.5 times the bicarbonate plus 8, plus or minus 2. If the measured carbon dioxide is higher than expected, there is a concurrent respiratory acidosis. If it is lower, there is a concurrent respiratory alkalosis. That is how you catch a mixed disorder, and only after that do you calculate the anion gap. Last pair, and this is where most students lose easy points. A diabetic on an ACE inhibitor has a normal gap metabolic acidosis with high potassium. The renal tubular acidosis look like an impossible memorization task, but there is one value that sorts them instantly. Check the potassium first. Types 1 and 2 are both hypokalemic. Type 1 is distal. The collecting duct cannot secrete hydrogen ion, so the urine cannot be acidified, and the urine pH stays above 5.5 even when the patient is acidemic. Because the urine stays alkaline, calcium phosphate precipitates, giving stones and nephrocalcinosis. Associations are Sjogren syndrome and amphotericin B. Type 2 is proximal. The proximal tubule cannot reabsorb bicarbonate, so bicarbonate is wasted until the serum level drops low enough that the remaining capacity can keep up. Distal acidification is intact, so once that new steady state is reached, the urine pH is below 5.5. Type 2 rarely travels alone, so look for the rest of Fanconi syndrome. Glucosuria with a normal blood glucose, aminoaciduria, phosphaturia, and uricosuria. Type 4 is the odd one out and the most commonly tested, because it is the only renal tubular acidosis with high potassium. The problem is not enough aldosterone effect, either deficiency or resistance. So the distal nephron cannot secrete hydrogen or potassium properly. Causes are diabetic nephropathy first, then ACE inhibitors, angiotensin receptor blockers, NSAIDs, spironolactone, calcineurin inhibitors, and Addison disease. So check potassium first, then urine pH, then look for proximal wasting. 3 steps, 4 diseases. Let's lock it in. Peak T waves progressing to flattened P waves and a widened QRS is hyperkalemia, while flattened T waves with prominent U waves is hypokalemia. Added acid opens the anion gap, while lost bicarbonate keeps it normal because chloride takes its place. And always run the same order. Find the primary disturbance, check whether compensation is appropriate, and only then calculate the gap. The Winter formula tells you whether the lung is compensating correctly, and any deviation means a second disorder is hiding in there. For the renal tubular acidosis, high potassium is type 4 and low potassium is type 1 or 2, split by urine pH. And the habit to keep: never interpret compensation until you have named the primary problem. That is part 5. Part 6 closes the series with the urology side: stones, upper and lower urinary tract infection, kidney and bladder tumors, and the prostate. See you there.